Today we will discuss about the pediatric fluid management, evidence-based pathways for resuscitation, maintenance, and electrolyte control. The physiology-based fluid replacement phases are divided in 4 phases. Phase 1, bolus, Phase 2, maintenance, Phase 3, homeostasis, and Phase 4 in the interval of pivot. Phase 1, that is bolus. It focuses on rebuild the tissue perfusion, the goal to avoid or decrease the end organ injury. In the phase 2 maintenance, the focus mainly on the shift from bolus to maintenance fluid, a critical window to maintain balance between intake and losses. In the phase 3 homeostasis phase, we are focusing about to achieve internal fluid balance between requirements and losses. And in phase 4, IV fluid administration is stopped and oral or enteral fluids are started. The body's intrinsic regulation takes over. In the bolus phase, phase 1, the rule is for acutely expanding intravascular volume, safe solutions include normal saline, 0.9% saline, and Ringal lactate. The pitfall is crystalloids have a short retention time due to their solute. 15 to 30% retain in the intravascular space and 70 to 80% going into the interstitial space. Key takeaway: isotonic sodium containing solutions expand the intravascular space temporarily. Expect significant interstitial distribution. For phase 2, in a healthy child, baseline maintenance is calculated by the Holliday Segar formula. 24-hour daily maintenance is calculated as for up to 10 kg. For every kg, 100 ml per kg is given from 11 to 20 kg with addition of 1000 ml plus 50 ml per kg for every kg above 10 kg, and more than 20 kg, for every kg above 20 kg, 20 ml per kg is added with the 1500 ml. Let's say a 15 kg child. What will be the total maintenance fluid within 24 hours? That is for first 10 kg, 1000 ml. The next 5 kg, 50 ml per kg, 5 into 50, that is 250. So total is 1250 ml over 24 hours. It is approximately 52 ml per hour. For a 25 kg child, what will be the maintenance dose of fluid in 24 hours? First 10 kg, 100 ml per kg, that is 1000 ml plus next 11 to 20 kg, 50 ml per kg, that is 500 ml. From 21 to 25, that is above 20 kg, 20 ml per kg, 20 into 5, that is 100, total 1600 ml per 24 hour, that is approximately 66.7 ml per hour. So the normal maintenance fluid calculation is clear to all of us. Next, the clinical pivot, assessing the critically ill child. We have discussed about the healthy child. Now we are discussing what are the assessment needed for critically ill child. You have to find out the fluid output, that is the urine output expected for the age and weight of the child, and what is the metabolism rate of the child, and what are the electrolytes of the patient, what are the sodium potassium status of the patient, and what are the other losses, any abnormal losses like they have surgical drains or diarrhea, vomiting, any other losses should be calculated and added as per requirement of the critically ill child. There is a year-long debate about the what fluid to be used as a maintenance. American Academy of Pediatrics recommends the isotonic fluids with added potassium and dextrose for the children 1 month to 18 years. What is the benefit? It mitigates the hyponatremia risk. But you should monitor the side effects. Watch for hypernatremia, hypertension, fluid overload, and metabolic acidosis. So why not the hypotonic fluids? The danger is it leads to increased incidence of acute hospital-acquired hyponatremia, and it may lead to severe consequences like hyponatremic encephalopathy. So it is better to use isotonic fluids as a maintenance fluid. Here we are seeing the compositions of usually used fluids in the wards and ICUs. All the fluids have components as glucose except for Ringal lactate, no glucose, and Plasmolite, no glucose. Now what about the sodium? For sodium, the 0.9% sodium chloride, that is the normal saline, has a sodium of 154 and chloride of 154. For half NS 0.45% NaCl, that is half of it 77, 77. And if you add D5 with it, glucose will be 5,5. Okay, you just remember the 154 in the 0.9% sodium chloride solution, and in the ringer lactate it is more or less 130 and chloride is 109. Ringer lactate has special component, that is the potassium. So ringer lactate is a potassium containing fluid. What are the others potassium containing fluid? That is Plasmalite, it has 5 milliequivalent per liter potassium, and Isolite P, that has 20 milliequivalent per liter potassium. And what about the calcium and magnesium? So only ringer lactate has calcium, what we are using day by day. So calcium and potassium ringer lactate. And if we are talking about magnesium, magnesium Plasmalite, magnesium Isolite P, and magnesium. So Isolite P, potassium, magnesium extra, ringer lactate has potassium and calcium. Okay. Now, what about the osmolarity of these fluids? The normal isotonic fluid, that is the 0.9% sodium chloride, is isotonic to our body. What is the normal osmolarity of our plasma? 280 to 295 milliosmol per liter. Now, the 0.9% sodium chloride with added 5% dextrose has the osmolarity of 308. It is also true for the 0.9% sodium chloride. Just add 154 plus 154, that is 308. And what about the 0.5% NaCl? Half of it, 154. And these all are the hypotonic fluids. And what are the isotonic fluids? So ringer lactate, 0.9% sodium chloride, and plasmalite are within the isotonic fluid level. Now, before prescribing the maintenance IV fluid, we have to look about what is the sodium of the patient. If the serum sodium is between 125 to 135, that is hyponatremic level, we use DNS, that is normal saline with 5% dextrose, or we can use ringer lactate with 5% dextrose. Okay, if the serum sodium is in the normal range, that is 135 to 145 milliequivalent per liter, we can use the same, that is the DNS or ringer lactate with 5% dextrose. But if we had the serum potassium level at the range of 145 or 155, that is the hypernatremic level, we are using N by 2 with 5% dextrose, that is 0.45% normal saline with added 5% dextrose. Now, what is the osmolarity of this fluid? Comment on the chat box. Let's move forward. What are the reassessment are needed and what is the escalation triggers? So we have to monitor the serum sodium and change the fluid accordingly. For the sick patients, we are doing the serum sodium 12 hourly if required, much earlier like 4 hourly or 6 hourly, and you can monitor 24 hourly on the more or less normal patients who are on maintenance IV fluid to monitor the sodium level. And if there is persistent dangerous sodium levels, like sodium remains persistently high more than 155 millimole per liter hypernatremic range, or sodium remains persistently low below 130 millimole per liter hyponatremic range, then you should investigate and refer to the specific fluid management for hyper or hyponatremic protocol. We are not using the standard pathway for these patients. What are the special population where the exception for the isotonic fluids are used? Especially for the neurosurgical disorders, cardiac disorders, renal failure patients, malignancy, diabetes insipidus, or severe burns, we do not use the standard isotonic fluid protocols because these are not well studied in this group. Fluid composition must be standardized and individualized based on the specific serum electrolytes of these kind of patients. What is our today's take-home message? Calculate 24-hour maintenance using the Holliday Segar formula. For the critically ill patients, always adjust this maintenance fluid according to their urine output, extra fluid loss, their sodium-potassium balance, and metabolic needs. Always go for protection of the brain. Default to isotonic fluid with added sodium and dextrose as per American Academy of Pediatrics to prevent hyponatremia. Monitoring is must, 12 hourly in sick childs, and ensure that lab equipment is well calibrated, otherwise your fluid management will be massacred. What are the common pitfalls? Volume overestimation. Don't forget that 70 to 85% of 0.9% NS or RL shifts to the interstitial space. Look for the hypotonic danger. Don't use the hypotonic fluids for routine maintenance. That's like Isotonic P or 0.4% normal saline with 5% dextrose, because it has the high risk of encephalopathy. Don't follow any blind protocols. Don't apply standard isotonic rules to renal patients, cardiac patients, neurological disorders, or burn patients without individualizing. That's all. If you have any questions, kindly comment. Now we will discuss about the electrolyte requirements daily in 24 hours. For sodium, it is about 2 to 3 milliequivalent per kg to 2 to 4 milliequivalent per kg. Now in the available IV fluids, what is the concentration of sodium? In the 3% NaCl, each ml of 3% NaCl consists of 0.513 milliequivalent per ml, that is more or less 0.5 milliequivalent per ml. And for the 0.9% normal saline, we have 154 milliequivalent of sodium in each liter, that is 0.15 milliequivalent of sodium per ml. So you can cross check your what is the maintenance fluid and how much requirement is made with that maintenance fluid. In the critically ill patients, you have to add or subtract sodium according to the sodium of that patient. Now going into the potassium. What is the daily requirement of potassium? That is 1 to 2 milliequivalent per kg, and each ml of potassium chloride has 2 milliequivalent of potassium in each ml of potassium chloride. So let's discuss how to add potassium in an IV fluid bag. The mixing logic for custom bag is mentioned here. The formula is volume to add into ml equals to ml of potassium chloride equal to required milliequivalent. Let's say for a 10 kg child, the required potassium in milliequivalent is 20 minus already in bag. Let's say in a DNS, there is no potassium. So already in bag is 0, and concentration of vial milliequivalent per ml for potassium chloride, here it is 2. So it is 10 ml. 10 ml of potassium chloride to be added for a 10 kg child. Total maintenance fluid, that is according to the Holliday Segar formula, is 1000 ml. So 1000 ml of DNS and 10 ml of potassium, providing the 2 milliequivalent per kg daily requirement of potassium. So the ratio to remember in the daily basis, 1000 is to 10, that is 100 is to 1. Okay. Let's say you are giving Isotonic P. So Isotonic P has a potassium of 20 milliequivalent per liter. If you are giving Isotonic P in a 10 kg child, then potassium requirement will be met. But Isotonic P is a hypotonic saline, hypotonic solution. It has lesser content of sodium. It may lead to hyponatremia if given for a longer time. Okay. Now moving into the calcium. What is the requirement of calcium? Elemental calcium 1 to 2 milliequivalent per kg, approximately 200 mg per kg of calcium gluconate. And 10% calcium gluconate, which is supplied in our ward, contains 0.465 milliequivalent per ml, more or less 0.5 milliequivalent per ml. That means 2 ml of 10% calcium gluconate equal to 1 milliequivalent of elemental calcium. Okay, so daily requirement is approximately 2 to 4 ml of 10% calcium gluconate per kg. Okay, and calcium gluconate have to be diluted with 5% dextrose or 10% dextrose or distilled water as a ratio more than 1:2 or 1:3 or 1:4 can be given. So if you are giving 2 ml of calcium gluconate, then you have to add 4 ml of 5% dextrose or 10% dextrose to prepare the final solution and give it over a 20 to 30 minutes slow infusion and monitor the heart rate. Check the baseline heart rate, and during the infusion you have to monitor the heart rate. If the heart rate drops more than 10 to 20 beats per minute or bradycardia appears, then you have to stop the transfusion. And calcium should be given through a fully patent, preferably fresh IV cannulation. Otherwise, if it extravasated, it will lead to thrombophlebitis, sometimes peeling of the skin, necrosis around the tissue where the extravasation occurred. So calcium infusion should be given very cautiously. It is better to avoid add calcium in the daily maintenance fluid bottle. Okay. And magnesium requirement is 0.3 to 0.5 milliequivalent per kg. The magnesium containing fluids are Isotonic P and plasma light. Both have 3 milliequivalent of magnesium per liter. So if you are giving 1000 ml of IV fluid over 24 hours, the requirement of 3 milliequivalent per kg in a 10 kg child is met according to the magnesium requirement. Okay. And what about the sodium bicarbonate? 8.4% sodium bicarbonate has the bicarbonate of 1 milliequivalent per ml. In the special situations, we are giving the bicarbonate correction. For that, you must remember that 1 milliequivalent bicarbonate is present in 1 ml of 8.4% sodium bicarbonate. Okay, this is the basic of the daily requirements of electrolytes. You first know the basic, then only you can give the advice in practical settings. Thank you. That's all. If you have any questions, kindly comment.